Perfect. All right, I'm gonna share my screen. Give me one moment. Everybody see that okay?
Yeah.
All right, go ahead. Thank you.
This is a 42-year-old female. She was diagnosed with hepatitis C about 6 years ago. She started using drugs about 11 years ago. She has a history of IV drug use and cocaine use. She's been clean about 3 years. She did go to rehab. She's continuing going to rehab meetings. She was incarcerated for 2 years, so I'm not sure the exact mode of transmission there, but she's never been treated for hepatitis. She does smoke 1 pack a day. She has a history of a tubal ligation. Her overall exam was normal. Her ultrasound showed mild diffuse fatty liver disease. Elastography was F0. We did order the Hep A and Hep B vaccines for her. She does have anxiety, depression, asthma, and opioid dependence. She's currently on citalopram 10 milligrams with dancetrone, Suboxone, and albuterol as needed. Her BMI is 23.9. Overall, her labs are pretty good. Platelets were 203, LFTs were good. Her APRI was 0.3, child was 5A, and MELD score was 6. Vitamin D was 57.3. Genotype is 3A, viral load is 63,000, and serum fibrosis was F0 as well. Overall, I think this is a pretty good case, straightforward. I don't think there's any interactions with medications, and I'm assuming Maverick would be okay with this.
Thank you so much. Does anybody have any questions for Gary before you go into the recommendations to see if Maverick would work okay? All right, go ahead and unmute for Gary if you have any recommendations or comments.
Gary, this is Kaylee. I agree Maverick for 8 weeks would be appropriate. And you hit on all the points. She's of childbearing age, but she's had a tubal, so we don't worry about the pregnancy concern in that regard. She seems to be doing well with her recovery, and no drug interactions foreseen, and you're doing the Hep A and B vaccines. And so I think everything you've touched on is appropriate and good to go with Maverick.
Sounds good.
Excellent. Thank you so much. Do you have any other questions, Gary?
No, I'm good. Thank you.
Perfect. Thank you so much again. All right. And Dr. Fournier, you ready?
Oops, I was going to make one comment.
Oh, sorry.
My bad. No, I just remember that this is a person that we're excited to treat because they're genotype 3, and you have less than 10 years of disease, and 3 modalities that all agree that there's no fibrosis. So that's awesome. But this is still one of these people that is at higher risk of rapid progression. And, I was kind of shocked on this one. Her BMI is 23 and she's got a fatty liver, which is, proof that they don't always correlate. There certainly is a correlation between obesity and non-alcoholic fatty liver disease, but it's not a prerequisite. So very interesting. And I'm glad you have elastography, by the way. That's cool. Anyway, good job. Agree with Kaylee. As always, well worked up patient, and happy to eliminate that genotype 3 from her body.
Absolutely. Thank you so much. All right, Dr. Fournier, I'm going to share a case. Give me one moment, please. Can you see that okay?
Yes, I can. Thank you very much. My patient is a 39-year-old male who has known for about 19 years that he's had hepatitis C. He has never previously sought treatment. He grew up in a family where drug culture was the norm, started using drugs at age 13, injectables at age 15. Like he said probably around age 19 is when he found out he had hepatitis C. About a year ago, decided to change up his life, and he has been in a successful MAT program on methadone therapy. He's stopped all the relationships with drug people in his life. His girlfriend, who actually, he tells me, also has Hep C, is not into drugs, and he has started going to college for business classes now. So that's why he wants to get treated and make his life better. His comorbidities are anxiety, depression, PTSD, hypertension, low testosterone. I have his meds up there: amlodipine, methadone, PRN albuterol, bupropion, sumatriptan, PRN for migraines, and androgel. He is scheduled to start the Twinrix vaccinations, I believe on the 20th or 21st of this month. He is 71 inches tall, 312 pounds, kind of a big guy, BMI at 43. Labs, normal CBC. His APRI was 0.29 with a trial Turco-Pugh of 5 class A, MELD score of 7. His serum fibrosis marker was F0. He is HIV negative. He is genotype 1A. His viral load is 174,000. He is scheduled for a liver sonogram on the 11th, in 2 days from now. But I felt like we can go ahead and get treating him, especially with the favorable, fibrosis markers, and looking at his meds. I don't see any problems, and I thought Mavorite would be appropriate for the shorter treatment course.
Thank you so much
Thank you.
for that case. Thank you. Does anybody have any questions before we go into the recommendations?
Hey, Dr. Fornia, John Gillipoos, quick question. Is he a smoker?
So yes, but he has also made great strides in that he smokes a half a cigar a day now. He's trying to quit.
Yeah, man, what a cool inspirational story.
Mhm.
Dude's getting his life in order. It's these are the
Yeah.
happy.
Perfect. Thank you so much. Any other questions? All right, we'll go into the recommendations portion, or any drug interactions portion.
I guess I'll go. I was waiting for Kayla to go because she does it better. The yeah, so agree with you. We had genotype 1A. The sky's the limit from your treatments. You could do Harvoni, Mavorite, or Epclusa. Your Zepatier would require extra testing, so probably not on the table.
Yeah.
You don't have any advanced fibrosis, and I agree with you. Shorter is better. So the Mavorite sounds like a good plan. No need for long-term HCC screening. I like that you're doing his liver ultrasound just to get a sense of morphology, and maybe looking for fatty liver because he's a bigger fella.
Big guy.
Yeah. The reason I ask about the smoking is his hemoglobin.
Mm.
You don't see hemoglobin of 17 that often
Mm-hmm.
outside of a smoker. And
Right.
The other explanation is his androgel.
Mm-hmm.
I don't think we talk about this very often, but as we're trying to convince people to not do drugs, I think we should emphasize more and more how much, because no guy wants to hear the word hypogonadism. That's like on nobody's wish list. But
Right.
that's one of the gifts of opioids and chronic narcotic use. So it's he's a 39-year-old on androgel, and the why there is not bad luck. It's well, actually, it is bad luck. It's the family he was born into, and the fact that he was using drugs since 13. That's just mind-boggling and horrid. But he's 39 years old, and he's had 25 years of Hep C. I mean, it's crazy. Likely 25 years of Hep C. Now, the good news is he doesn't have any advanced fibrosis. He's likely one of these people that never would get any. So, years ago, he'd be one of the people where it's probably fine. We're like, all right, you're the 1/3 of people with chronic hep C who doesn't develop chronic liver disease. And but nowadays, we obviously, for all the reasons we always talk about, morbidity and extrahepatic manifestations and all the other reasons, decreased transmission, et cetera, we want to treat him. So let's do it. But yeah, I just always, both marijuana and opioids can do the hypogonadism. I don't know if it reverses, but he's on methadone, so it probably won't reverse while he's on that. So just an aside, nothing on hep C, but an interesting extra negative that drug use does to us. Kaylee probably has something smarter to say than I do.
Man, you covered it. I have nothing to add. That was great. Good case though. His story is very, very, it just touches my heart, because he's the kind of patient that we like to follow and see, and it's just always a testament to humanity whenever someone that struggled and just had poor fortune throughout his life has really turned himself around. So that's great. But I think treatment would be wonderful for him.
Thank you so much. I agree.
Thank you, everyone. Dr. Fournier, do you have any other questions?
I do not.
All right. Thank you again for submitting cases. This group's so awesome about that. Thank you. All right. So we'll just go ahead and open the floor about any questions or discussions on the new guidelines that we have going on right now.
What are the new guidelines that you're referring to?
It's Medicaid, correct, Mitra and Dr. Gilfus? I don't know.
Yes,
This is open for you guys more.
yeah, we had a few questions come in from some participants, so that's why we thought maybe opening up the floor for discussion. But since we're not clinicians, we don't know the details and we don't want to relay it incorrectly. So I was just gonna say, anyone who has any comments or information about what the new guidelines of a complex case entails. I know we met with Medicaid and they kind of discussed that as well. So just wanted to open it up for anyone with questions, comments. Rachel, I saw you unmuted. Go ahead.
Yeah, I was just going to chime in. The changes are really kind of what Mitra alluded to here just now with complex versus really, I don't remember what the term they used, but more like a straightforward patient. So the updated criteria that they did, I can't remember if it was in June, it was relatively recently, is that if your patient is straightforward, so not pediatric, so 18 years of older, they've never been treated before, they don't have cirrhosis, they don't have co-infection with hepatitis B or HIV, obviously not pregnant, those sort of things, then the ECHO or West Virginia HAMP consult is not required, but they still highly recommend it. So you could submit authorizations for these straightforward patients without having to say that you were consulted via ECHO or West Virginia HAMP and name the provider NPI like you guys are probably doing now. So that's really the main update. So if they don't meet that criteria and they're a more complex patient, then they do want to see that consultation with a specialist, so GI, hepatology, IED, to see if the consult for the complex patients are happening. So that's just a short version of the changes that they made recently.
So in essence, they're not doing anything to restrict, they're actually loosening prescribing, which is really progressive. That's interesting. I don't think I was aware of that.
I think I've been hearing that, but it seems that whenever I try to send a case, for authorization, because of course we still have to do prior authorization, I get it back saying, well, who did you talk to about this? I mean, what specialist did you run it by? And, I did manage to get one through that I hadn't presented, but it was just kind of, they're still asking on that end, or they were a couple of weeks ago the last time I tried. Perhaps that has changed now.
Yeah, that's exciting. I'm glad you were able to get the one through. And I think probably because rational drug therapy or RDT, they're the ones that are doing the prior auth or administering that prior auth benefit for West Virginia Medicaid. So they're probably, if I were to guess, and I wish Angie were able to join today from RDT, they're probably still going to ask just for the foreseeable future, because a lot of times when these changes happen, sometimes it's a trickle to get them to kind of change what they're doing in their process and educate their folks when they're doing these. So they might still ask. If you don't mind, when you sent it back and said like this, did you say like this is one of those straightforward or non-complex patients? I didn't do a consultation. Is that like how you worded that to get them to change their mind and let it go through?
Something of that sort. I just said, the patient has no complications and appears to be otherwise healthy. Please let us treat her. Something of that sort.
Yeah, and that might be all they need is just to have that reinforcement and then submit it. So good, that's awesome.
Rachel, Mitra, Elizabeth, do you guys, what's Brian's last name? The main pharmacist who runs West Virginia Medicaid, not RDT, but
Thompson.
Thompson, yeah, and he sometimes joins this group, but I'm not sure if he's able to.
Brian had a request when he was on here a couple of weeks ago, where if you get a situation where someone is still refusing a straightforward case, to inform him about that. He thinks it's just like Rachel said, going to be a slow uptake while the pharmacists who do the prior authorization learn the new rules. So he had specifically mentioned that he didn't think that everybody would, all the pharmacists doing the prior auths would know these new rules immediately, but hopefully the uptake will come. And he specifically wanted to know if you were getting kickback on these straightforward cases. And I can probably get his email for you if you need it. I just don't have it off the top of my head, but I think we have it somewhere on record.
I have it as well. I'm happy to chat it in.
That'd be great. Yeah, because again, it was sort of his request. He wanted to hear about these cases if we're having obstacles to well-educated, experienced providers like all of you on this call. I have 100% confidence on all of you on this call in being able to do this. The one thing I will say, hepatitis C, after however many years, coming up on, anyway, I don't want to say how long time. For a long time, I've been treating hepatitis C, and man, it is crazy the number of zigs and zags this disease process can take, and the curveballs it can throw at you. You may randomly be able to come up with about 8 to 10 variables that you're collecting, but like a Rubik's Cube, that can come up with a lot of different patterns. And I think Kaylee will attest to this too. I am endlessly amazed by the potential complexity of even some straightforward cases. So I always want to encourage you to submit cases, ask questions, look for clarification any way you can, either through on demand or via echo. Don't feel like because Medicaid's saying you don't have to ask, that you shouldn't ask. So if you have any questions, please let us help still. And again, those complicated cases are just great examples. Pregnant people, HIV co-infected, Hep B co-infected, cirrhotics, prior treatment failures, etc.
I always find there, just to reiterate what you're saying from a spokesperson perspective, I always find it so helpful to present because there are subtle things that I learn, or overt. I mean, they're just something I learned from everybody's presentation and from the presentation of my own. So I would probably continue to, I'm sure I would continue to submit. It's just really so interesting and helpful to talk it through with you all. But that's good to know about the change.
Yeah, just remember, I mean, this is really to increase access to care. And so that's why they've made these updated criteria. But yeah, just like you've said, Jen and Dr. Gilfus, for sure, we want you to present cases to us. There is no simple or complex. It's really, this echo is for for you guys. So, it's whatever you want to make into it. So if you have any cases that you want to present, I don't care what the Medicaid criteria says, feel free to please continue to present those, because it's reiteration and, repetition. This is all good for everyone on the call. And sometimes we get new spoke members that join that it might be their first experience with Hep C. So we don't only want to present the most complex cases. It's really good for everyone as a learning experience to go through these. Just know that you don't have to, if it's going to delay your patient getting care or treatment. You can go ahead and proceed with that without our blessing, if that works better for you and your practice, or when it does, I should say. I had one comment, maybe with the possible kind of barrier, because again, a PA is just time consuming, and then to get a kickback and have to appeal it and write a letter, that's all very time consuming. So just until it does become more widely adopted with RDT and understanding the new criteria, maybe if when you're submitting cases, just right at the top of it, per updated Medicaid or DHHRPA criteria, this Hep C consult does not require a specialist approval, or just some kind of blurb at the top of that. That way it might have RDT kind of just take a second look at, oh yeah, this is the criteria and they do meet it, until it gets to become more standard practice for them to review it that way.
Thank you. Does anybody else have any questions or comments on the subject? Go ahead, Dr. Rexrod.
Well, I was just going to kind of echo what Jen said, that, I think we all learn from all of these cases, and that's kind of how mind works, is if there's a story to attach to it, like the gentleman we heard about today. But yeah, I think I would continue to present some of them. And I have found, we've gone over some of the basics of Hep C. We've been at this now for a couple of years, and I feel like I learn something each time we go back to the basics of it, because it's like I speak the language now or something. I pick up on things that I maybe didn't the last time. Plus, I think this is always evolving, like a lot of things in medicine. And so, I appreciate the availability of the people who can keep me up to date on it.
Absolutely. Well said. Thank you. Dr. Gilfills, go ahead.
Oh, just thank you to Jennifer and Carmen for saying that. You just filled Kaylee and my soul with Danny, it made us feel great. And I think the motivation for Medicaid changing these is great. The issue, nationally, the CDC has, really talked about how we are not yet winning the Hep C battle. The fascinating bit of information that was published this past summer is that it looks like, I'll read the article, it's read to you. It says approximately 120,000 people were treated each year in the US for Hep C, and that for us to win, for hepatitis C to be eliminated, you need to get that level up to about 260,000 people needed to be treated each year to really look to eliminate Hep C. And it's interestingly enough, there's fewer people being treated for Hep C in 2020 and 21 than there were in 2016, 17, which is pretty wild. And so I think that's the impetus that you're seeing, that they're trying to make it more accessible, because even though we have these good curative treatments, good access to them, we need to actually expand access further. But any way we can help, I think all of us here love doing the ECHO program. I feel like y'all are friends and colleagues at this point, and it's fine. I'm glad you find this worthwhile.
Absolutely. Really grateful for all of you. Does anybody else have any questions or comments? If you do think of any, of course, bring it to the next session or email us. We'll be happy to put it to whoever needs that email. All right, my only announcement for today is our next session is September 22nd with Jean Kernel discussing liver lesions and HCC. I hope you guys have a great rest of your week and we'll see you soon. Bye-bye.
Thanks, everyone.